Now I get the pleasure of introducing our morning keynote speaker, Farah Hanley, who you all know. But Farah is the Chief Deputy Director for Health, overseeing the BPHASA, Behavioral Physical Health Aging Services Administration. Between 2014 and 2022, Farah was the Senior Deputy Director for Financial Operations. She's served as manager of MDCH budget within the State Budget Office, where she assisted MDCH, those of us who remember that acronym, and the State Budget Office in key decisions, including implementing the Healthy Michigan program. In addition, she served as the Federal Health and Budget Specialist within the State Budget Office. Prior to that, she served as the Senior Medicaid Consultant to the MedStat Group, now IBM, where she developed analytic methods and supported policy analyses for state Medicaid programs across the country. Governor Whitmer appointed her as the acting director of MDHHS in January of 2019, before Robert Gordon came in as the director. So, without any further ado, Farah Hanley.
Good morning. I want to first say that I did not plan this delay. None of us did, and we appreciate your patience. I was sitting there wondering, is this sort of the test of how patient can our health policy experts be? Sort of like the lessons I talk to my kids about. How patient can you be? So thanks for sitting there and holding up here while we were getting set up. So thank you so much for having me here with you today. It is a real pleasure to share with you all the work we're doing at DHHS now that we've entered sort of this different phase from when I last spoke with you. Today I'd like to share my thoughts on what we experienced and how the public health emergency brought in a new era and a new way of thinking about healthcare structures, programs, and policies in our state. You all were not the only ones who experienced a seismic shift in perspectives, and I'm going to share with you some of what I believe is happening, and it's not happening to our most vulnerable individuals in our state. We try to stay away from the term most vulnerable in our department and really remember that this is about our neighbors, our family, and our friends. These are folks that are nearby us on a day-to-day basis, and we have to remember that. Everyone is shaped by their experiences, and for those who receive some public support, they too are working through this very seismic shift. So I want to talk about who we are and what we're doing with the healthcare industry to really chart the course of health policy. First, we'll talk a little bit about the department, and then we'll shift into how the healthcare system, from the department's perspective, has adjusted, where our programs and processes have had to be more nimble and fluid. And for those of you who don't work in state government, I will tell you that is no small feat. We'll talk about what issues were not only revealed, but as I say, were exacerbated by the public health emergency. What continues today, and what we've learned in terms of lessons and how this informs what we'll do in the future. So a little bit about us. We are the Department of Health and Human Services, and we have a mission. And our mission is to provide opportunities, services, and programs that promote a healthy, safe, and stable environment for residents to be self-sufficient. That's our simple mission, even though our department is anything but simple. I love this department. I have worked in it for 1/3 of my professional career. And I will tell you that every day is hard. And as for many of you in your work professions, every day is also rewarding. Our agency is the single largest agency in the state, representing 43% of the state Michigan General Fund budget. We are larger than the worldwide revenue of McDonald's Corporation. We also represent 1/3 of the state employee workforce, with 2,500 employees only in our 5 state psychiatric hospitals and centers, and thousands of local office workers in the state, including our CPS and foster care workers, eligibility, and others. From a statistics perspective, there's a lot here, but I will just highlight a few items. We have nearly 1.2 million children enrolled in our Healthy Kids Dental program, and 370,000 individuals and households receiving basic heating assistance. We have funded more than 800,000 emergency shelter bed nights and supported 288,000 who participated in substance abuse prevention programs. We operate state-operated secure residential facilities for juveniles and support services for nearly 10,000 foster care children in the state. And we funded 10.3 million home-delivered congregate meals provided to the aging population in Michigan. This is just to name a few. It will take a while to really process everything we do, and the reality is this is just a small piece of what we do. So I just want to talk to you a little bit about our agency and the programs we support. Our health services programs are vast. Our programs are generally split in the Medicaid and non-Medicaid funded category, each though equally impactful. Nationally, Medicaid is a $730 billion program, and according to the Kaiser Family Foundation, Michigan is the 9th highest in Medicaid spending in the country. Michigan spends more on behavioral health and substance use disorder services only on these 2 components, more than compared to the annual revenue of Twitter. That is only those 2 bullets up there on the chart. So our spending is large, but so too is our reach. And every day we're working to take advantage of it and to fulfill that mission of providing opportunities, services, and programs that promote a healthy, safe, and stable environment for residents to be self-sufficient. As a famous saying among many health policy experts goes, you've seen one Medicaid program, you've seen one Medicaid program. In Michigan, almost 1/3 of our state population is enrolled in the Medicaid program. This includes more than 1 million children, 326,000 people living with disabilities, 157,000 seniors, and other individuals. While a sizable portion of individuals are children and families, the significant costs are associated with serving the aging population and those living with disabilities. Those are reflected with the disproportionately higher costs of care for that smaller population. All right, so now I've given you the very thumbnail, I would say pinky nail, view of our agency and what we do. I'd like to now venture into what happened when, very casually stating, everything blew up. What happened in the department and what did we learn from it? So I'll spend not a lot of time on what happened and more from what we did to build off of converting chaos into opportunity. We know there's a lot that took place, but I will narrow that lens and take you on this journey into some of the primary issues that really came into focus at DHHS and continue to be built upon today. When I attended the University of Michigan, I had my degree in organizational behavior and psychology. And one thing we learned was the Bruce Tuckman team and group development model. It describes the different phases of team development, as you'll see there on the chart, and it shows that with team development, it begins in the forming phase, moves to the storming as everyone is trying to figure out where they're supposed to be, and then it transitions, builds up to a slow norming, and finally graduating to a performing phase. I've used this chart not only at school, but also at work, where, as some of you know, we participated and we were a part of the single largest state agency merger in state history. During the pandemic, We all, to some degree, went through each of these phases. For me, the forming was the beginning where we learned about what was happening overseas, and then a couple of cases in the state of Washington. And then I remember getting a call from Elizabeth Hertel, our current director, who was then chief deputy over administration, and she said, there are 4 cases in Michigan. That was most definitely the forming. The storming was obvious. We couldn't keep up with the cases. Hospitals were at full capacity, and the behavioral health and crisis systems about to collapse. There was just a lot. To say that we're slowly moving to a norming phase would be inaccurate. I would say we found a slow rhythm of sorts that might be characterized as norming, I suppose. Performing in this context is really whether we're able to sustain the programs and policies in a way that furthers quality of and access to care. Performing is building off of the lessons learned, those new discoveries that get us out better than we went in. Those new discoveries are what I want to share with you today. Those new ways of thinking that if we can optimally perform, we can build off of that seismic shift and create momentum for something that's really incredible. So we've all been in a situation like this to one degree or another. We've reached a fork in the road. We had reached a fork in the road. Wikipedia says that a fork in the road is a metaphor based on a literal expression for a deciding moment in life for history when a choice between presented options is required. And once it's made, the choice cannot be reversed. Except in this case, there was no choice. A lot of us were going along our merry way just fine, and then we had to veer left. And I see that I'm up there and my chart's not, but we were all veering left. We were shoved into veering left. There was no choice. The pandemic forced us to move in that direction. We were in the forming phase, but it very quickly and inevitably turned into the storming phase I showed you on that previous slide for Tuckman's stages of development. People were under those dark clouds on that chart. They were all quitting their accounting jobs, turning into yoga instructors, and their great resignation began. And, in the health policy world, I really like to refer to it as the Great Assessment. Now we're 3 years in. We've gone through that storm, and the forked road is slowly merging into one lane again. But it's not the same road as before. This one looks different, feels different. And so what happened and what has changed? And that's what I'll be talking about with you today. After we got out of the storm, we had to figure out what to do approaching the norm. What did we need to do to continue what was working into our future? The light at the end of the tunnel that was no longer a train, but instead a shimmer of hope, a ray of light. Well, one thing we needed to do was to understand that in the age of social isolation, we had a responsibility to deliver health services by meeting people where they are. Michigan's health programs adjusted to the new way of living. We quickly implemented and expanded telehealth policies through Medicaid and our aging programs to continue supports and services. We learned that being flexible and nimble was the best way to do that. Telemedicine is that use of communication technology. We recognize that telemedicine can never fully replace in-person care, but MDHHS established principles to be used by the department-enrolled providers during the provision of telemedicine services. This framework of telemedicine remains as part of our overall healthcare picture today. While some policies have shifted to like annual in-person visits, from audio only to face-to-face, we are still looking at this as a pathway to the future of Medicaid health services, and it really speaks volumes to the changes we've been working towards. Our long-term care programs are vast and support a broad array of long-term care supports and services. We have integrated programs in the community in a residential setting. We have services for Michigan residents who are enrolled in Medicaid and Medicare programs, offer a broad range of medical behavioral health services, pharmacy, and others. We have hundreds of nursing homes in our state. And we heard from our people that folks wanted more options in the community. We heard from our nursing homes that they now had patients with really acute care needs. We needed to conduct another assessment that built upon the necessary changes in the healthcare space going forward. We're currently working closely with the nursing home and broader long-term care industry to rethink reimbursement for residential facilities, reimbursement that will promote quality of care and a better way of life. We're building out home and community-based services plans going forward to reinforce the need for expanded access in our communities. We are at the state hyper-focused on breaking down barriers to health equity. We talk about statistics, like Black women are 3 times more likely to die than white women due to childbirth. But last week, I and some of my colleagues attended the National Association of Medicaid Directors Conference, and we were listening to a speaker, and she said, we need to flip the narrative and talk about the why. Why is it the case that Black women die 3 times more likely than white? Maybe it's because our health system is failing our minority populations. Are we still living in a world of bias and inequity? It is 2023, and women, more so Black women, are dying from childbirth. I personally know someone who has been going through quite a bit with their health, and they have now turned into had a very high and successful professional career, and now an executive running a large corporation. They have gone from what individuals would say a statistic to someone who is thriving. It's about opportunities and knocking down barriers. We need to change the narrative to address the why and not treat the victims in the statistic as the reason. We've done some things to support and advance these causes, including providing 12 months of postpartum coverage to our Medicaid moms so they can have access to the full array of physical, behavioral, dental, and other services for a full year following birth. We also initiated and have implemented a policy allowing doulas to be a Medicaid reimbursable benefit. Doulas are trained birth workers who provide non-clinical, emotional, and informational support to pregnant women and their families. Doula services have been shown to positively impact the social determinants of health, support health equity and birth equity, and decrease existing health and racial disparities. This year, the governor proposed to add a recuperative care benefit to the Medicaid array of benefits. The proposal supports assistance to those who are homeless and discharged from a hospital. In these cases, often individuals will go to a shelter straight from a hospital where they are not equipped to manage the person's needs. This proposal will provide that program supporting a smoother transition and will reduce the rate of readmission into a hospital. Roughly 75% of unhoused Medicaid enrollees require access to medical services, some of which can involve hospital stays. After discharge, coordinating follow-up care can be extremely challenging, making effective treatment and healthy outcomes difficult to achieve. The recuperative care benefit, funded with an investment of $5 million, will provide these enrollees with a safe setting with which to properly recover and continue receiving care. We have a wonderful organization in Detroit, the Neighborhood Services Organization, who already does a lot of this work, and we know we can build off of a successful and already established template for the future. As health policy experts, we know that social determinants of health are the conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes. One step we've taken to address some of those social determinants of health barriers is to incorporate community health workers as a fee-for-service recognized Medicaid benefit. Ensuring Medicaid beneficiaries have access to culturally responsive services is a key driver of acknowledging community health workers as a trusted connection within the existing fee-for-service model. We are also excited about another new health policy path, and that is that we've submitted to CMS and are awaiting federal approval for a new targeted case management benefit as a method of improving care coordination and facilitating health improvements for Medicaid beneficiaries with justice-involved backgrounds. This benefit would afford Medicaid-enrolled, justice-involved individuals with a case manager to support them in accessing the healthcare services they need, including peer and recovery support services, addressing housing needs, provide transportation services, and support connections to employment and education. I would be remiss if I stood here today and didn't talk to you about the workforce. I want to just focus in on three broad areas. As I travel the state, the number one theme I hear, not only from our behavioral health providers, but across the spectrum of the Medicaid program, is the challenge related to workforce recruitment and retention. The three broad categories that we continue to hear shortage of, hitting providers the hardest, are first, direct care workers, and then second, nurses, and third, masters in social work and other related fields. Michigan ranks third in the nation with the highest shortage of mental health professionals, and we struggle to hire and retain enough qualified staff to provide psychiatric services statewide. This is no different in the direct care worker industry. The reality is that direct care workers have been on the front line of the public health emergency. These individuals take care of our communities and ensure that they are included as a valuable part of their community and empowered to live with the dignity all people deserve. We have approximately 165,000 direct care workers in the state, representing roughly 4% of the total employment. The direct care worker is overwhelmingly female, primarily has a high school degree, maybe some college, and is disproportionately Black compared to Michigan's general population. The workforce has a diverse age range, anywhere from ages 21 to 64, and some of the larger occupational categories are nursing assistants, about 48,000, and personal care aides, about 41,000. We know it's important to support our direct care workers, so we've spent close to $3 million to train our direct care workforce and to give them as many tools at their disposal as possible. We have, over the course of the last several years, but even more so now post-COVID, requested and have received funding from the legislature to provide hourly rate increases for our direct care workers. This year, the governor's proposing an additional $1.50 on top of the $2.35 that was proposed and received last year. Those incremental increases will help to narrow the gap so that people who have the mission in their veins to be a direct care worker can be prevented from going to work at a fast food chain restaurant because they could receive $4, $5, or even $6 an hour more instead of caring for a disabled individual. So if we can get that back on track, we're moving in the right direction. According to the Michigan Health and Hospital Association, since 2020, Michigan has lost 1,700 staffed hospital beds because of a lack of staffing. Vacancy rates are at an all-time high of 13%, and we all continue to hear about the shortages of staff in our large and small community hospitals. I spoke with the CEO of a large hospital system not too long ago, or a couple years ago, soon after COVID, and he said that he had 800 nurses, aides, and nurse assistants who left. And then I spoke to him again late last year, and he said he still doesn't nearly have the amount of influx coming in that he did in terms of the outflux. We've all had family members stuck in emergency rooms, not able to find a room, come to find out the hospital had a bed, but didn't have nurses to staff it. And a lot of times people are in hallways. This is something that we need to get better on. So we have partnered with Wayne State University and Michigan State University to expand cohorts for those degrees and are exploring additional efforts to build out these ideas to support clinical graduates. And for the third tier of concerns, we at the department hear, relative to the workforce, that there's a social worker shortage. We know there is one. As demand for youth and adult mental health services grows, the U.S. is facing a social worker shortage. Michigan is no exception. Some researchers believe that there are several reasons for this, as noted on the chart. Our department has launched a $3 million student loan repayment program supporting 324 behavioral health licensed professionals to assist them to get the degree they want with some support from the state. What's also exciting is that our external partners, like our behavioral health providers and our clinics, are doing some creative things to also help fill the talent gap. This year, Easter Seals Mork and Oakland University recently teamed up to fund 10 Oakland University grad students each year in exchange for a promise that they'll work for Easter Seals Mork for a minimum of 3 years after graduation. Easter Seals Mork is investing $500,000 annually to fund the scholarships and the cost of 25 paid internships for students, and Oakland University is also collaborating in this effort. I was so excited about this effort. I told Brent Worth, the CEO of Easter Seals Mork, that I would drive down to Oakland University when they had that press conference. And he called me up and he said, "It's next week." And I said, "I'm there." So we're really excited about this. At the Department of Health and Human Services, I, along with Al Jensen and Megan Groen, our new Medicaid director, chair a workforce steering committee that has a very simple vision: develop and implement comprehensive short and long-term approaches to address the workforce shortage. In addition to those items mentioned, there are several here that I won't highlight given our fantastic delay in the presentation, but you can go ahead and go through it. I know that the slide deck will be available to you. It's important just here to reinforce that we are doing everything we can to create flexible, nimble proposals that will address these critical issues. One of the more exciting things I think we've done is allow for Medicaid reimbursement of certain clinical degrees prior to receiving licensure, expanding public awareness campaigns, and even more. So we're really, really excited about what we can do here and the short and long-term impacts, because many of these will take time. We need to talk about the mental health crisis facing our state. The U.S. Census Bureau conducted a survey this year of state rates of populations with symptoms of anxiety disorder or depression. Michigan results showed that only for this survey, 31.2% of respondents suggested that they had symptoms of anxiety and depression. We know we need to do better to improve our services and make a difference in people's lives. So I want to talk to you a little bit about what we're doing and partnering with our behavioral health providers to advance really important work. I mentioned that we have very crowded emergency rooms these days. As you may have heard, we have individuals with mental illness who are or developmentally disabled, and they are not receiving the appropriate care because they're not in the appropriate setting, and they're either sitting in emergency rooms or in a hospital med-surg unit. We need to move individuals out of state psychiatric hospitals if they're ready to be discharged out to the community so our private hospital partners who are working hard every day to stabilize these patients can move them to other settings where they can be appropriately treated. In order for all of this to work, we've established the Intensive Community Transition Services Program. The goal of this benefit is to transition people out of state inpatient psychiatric care settings and into community-based care. It is specific now for individuals in state psych hospitals who are ready to be discharged. And through this program, we will be able to provide some relief on our hospitals and better move individuals to appropriate placements. All of these efforts really serve to strengthen the continuum of care. When we talk about crisis services, we talk about someone to call, which is MyCal, someone to respond, which is mobile crisis, and a safe place to go for help, crisis stabilization units. MyCal is our Michigan-specific predecessor to the National 988 hotline. Since 988 went live in July 2022, 988 has helped more than 39,000 Michiganders through answering over 50,000 calls. 988 staff have spent over 17,000 hours on the phone helping Michiganders in distress, and over 46% of these calls had high or overwhelming stress at the beginning of the call. After talking to a 988 specialist, this was significantly reduced to only 16% of 988 callers with high or overwhelming stress. For mobile crisis, while these are all separate initiatives, there is a significant amount of coordination behind the scenes internally to ensure that our policies align. We are internally staffing up, and work has commenced on the enhanced Medicaid match and our diversion fund mobile crisis. The adult mobile crisis model will be based on requirements for the model for youth and families that the department is also standing up. And then finally, our crisis stabilization units are required to be set up. They provide short-term and alternatives to emergency department and psychiatric inpatient admission for people who can be stabilized within 72 hours. Oh, let's go backwards. No, let's go forwards. All right, there we go. Michigan State Psychiatric Hospitals and Centers have been at the forefront of the mental health crisis we've been facing in our state. There are 5 state psychiatric hospitals and centers serving 650 high-needs patients here in Michigan. So we know that we need to engage differently as we look at all the work we're doing across the state. We know that we have an obligation to really better understand the beneficiary experience, and we're using technology to communicate and meet people where they are, to build relationships. At the level of engagement by way of relationships, what we've established is different. We have the strongest collaboration ever with providers, with the community, and even with CMS. CMS was at our conference last week, and much of the time, they were talking about how they can be helpful, how they want to assist us in any way possible. I've been doing this line of work long enough to remember that CMS always didn't feel very helpful. So the relationships have even changed, meeting people where they are and using technology to communicate. In terms of communication, Louisiana is spending $195 million only on outreach and communications as it relates to the PHE unwind and the Medicaid redeterminations. We are engaging differently. Medicaid managed care plans provide the delivery of Medicaid health benefits and additional services through contracted arrangements with the department. The large majority of individuals enrolled in the Medicaid program receive benefits through one of our 9 Medicaid health plans. The plans provide a comprehensive array of services to our 2.2 million Medicaid eligibles. While Michigan was a leader on this front, and Vern Smith and I can attest to when we started this in the early 90s, today, capitated managed care is the dominant way in which states, including Michigan, deliver services to Medicaid enrollees. But something really exciting is happening on this front. We are in the middle of what some have said is the largest procurement in state history. Our Medicaid and Healthy Michigan plans provide health care coverage to approximately 2.2 million Michiganders. Last summer, we initiated a survey seeking public input as we were beginning our rebid design process. We were thrilled to receive nearly 10,000 responses to the survey. Under the banner of My Healthy Life, our department seeks to bring together investment, creativity, and commitment to the department, its partners, including health plans, providers, and communities, to create a more equitable, coordinated, and person-centered system of care dedicated to ensuring Michiganders live a healthier and have a healthier future through 5 key strategic pillars noted on the slide. This procurement represents more than 15% of the Michigan gross domestic product of Michigan's economy. Given this large-scale impact, we know that we have an opportunity to be truly impactful when it comes to shifting the way we look at healthcare through that post-2020 lens. These 5 pillars are intended to support the ultimate goal, and that is for healthier communities to thrive. So looking ahead, we're really laser focused on so many things. Yesterday at the Health Policy Conference, I was listening to a presenter from the University of Michigan, and he said, it's about the power of we. How do we come together and turn the great resignation into a great opportunity? The status quo isn't enough. I tell people at work all the time, it's just not enough, it's not good enough. And last week, we heard a presenter say, don't let okie dokie be the okay response. I'm here to tell you that we in the Department of Health and Human Services don't ever settle for okie dokie. From the chaos came opportunity, and it's incumbent upon us to really build on that opportunity, to ride the wave, to reach that performing phase, and to meet people where they want to be, to engage them differently and more intently, and to meet people where they want to be, to engage them more intently, to identify the barriers that they have and knock them down. We are doing all of this with intention and with the desire to disrupt and make a difference in people's lives so that the mission of providing opportunities for residents to be self-sufficient can be achieved. Thank you for having me here with you today. I'm grateful for your time and effort. Thank you.